Hi, my name is Abigail Herrera Salguero. My topic about is Encorafenib, Binimetinib, and Cetuximab in BRAF-V600E. Mutated colorectal cancer. Definition: Colorectal cancer, also known as bowel cancer, is the development of the cancer from the colon or right part of the large intestine. Something symptoms may include blood in the stool and shakes. In bowel moments, we lose and feel tired all the time. The BRAF-V600E mutation occurs in approximately 10 of the patients with metastatic colorectal cancer with presence estimate range from as low as 5 to as high 21.
Well, basically, the BACON trial was designed to find new treatment options in patients with metastatic colorectal cancer that bear the BRAF V600E mutation. And we know that this accounts between 8 to 10% of the patients with advanced disease, and also we know from previous series that these patients actually have a poorer prognosis compared to the global metastatic colorectal cancer population. So the initial data suggested that as these patients had BRAF mutation, actually they could be sensitive to BRAF inhibitors, like for example patients with melanoma. But actually with the initial data, we realized that the activity was really very low, almost inexistent. And then when tried to understand in the lab which were the mechanisms of immediate resistance to BRAF inhibitors, and we realized that there was an immediate upregulate of the epidermal growth factor receptor, EGFR. So then we went back to the clinic and we decided to do the BEACON study, that it's a randomized study in patients with metastatic colorectal cancer that have been previously pretreated and that bear the mutation B600E, BRAF V600E. So we randomized a total of 665 patients in 3 arms. One arm containing a triplet, a RAF inhibitor, Encorafenib, a MEK inhibitor, Binimetinib, and an EGFR inhibitor, Cetuximab. The second arm, the doublet, only contained a BRAF inhibitor, Encorafenib, and the EGFR inhibitor, Cetuximab. And finally, the control arm was what it was considered a standard of care, and this was either irinotecan with Cetuximab or FOLFIRI with Cetuximab. And as initially expected with the preclinical and early clinical data that we had, the triplet combination did much better than the control arm. So the hazard ratio for overall survival was 0.52, translating the median survival from 5.4 months in this poor risk population to 9.0 months for patients that received the experimental treatment. Also, we look at the data on the doublet and we compare the doublet with the control arm, although this was not one of the primary endpoints of the study. And there was also benefit, slightly lower, with a hazard ratio of 4.60 and the median survival increasing from 5.4 to 8.4. But more importantly, as these patients are really very symptomatic when they have advanced disease, and also we show an important advantage in the overall response rate. So the overall response rate for the triplet was 26%, independently reviewed. For the doublet, it was 20%, and for the control arm, it was only 2%. But even more, in looking at the tumor shrinkage, according to the waterfall plots, patients receiving the triplet treatment tend.
Application in nursing. Patients receiving Encorafenib, Binimetinib, and Cetuximab triple therapy group. Encorafenib and Cetuximab dual therapy group, or the choice of the research for Cetuximab and irinotecan or Cetuximab and fluorescein.
So for BRAF mutant, there is a big change, okay, because multiple studies showed that triplet combination with a BRAF inhibitor in the center, with a MEK inhibitor now, before it was also tested with PI3 kinase inhibitors, and an EGF receptor inhibitors, in this case always Cetuximab, showed very promising results. In refractory patients, response rate over 30%, which is unheard for this disease. Now, recent data showed at World GI showed not only high response rate, but long progression-free and overall survival, which is the reason now the new concepts are that there is a trial being developed in first line. So now the interesting thing is this triplet has no cytotoxics, only target agents, which again indicate when you are smart in identifying the molecular genetics of the tumor, you can successfully interfere and have dramatic clinical effect without a lot of toxicities.
Pros and cons. Pros. BRAF insulin has only limited activity due to reactivity of the pathway from the signaling of the epidermal growth factor receptor. Cause. The most common adversity event in the therapy group were gastrointestinal, including diarrhea, nausea, vomiting, and dermatitis.
Management of patients with this particular subtype of colorectal cancer can be difficult because of how aggressive the cancer can be. We're fortunate that we now have regimens that are giving responses for patients. The activity that we've seen in patients getting treated with the Binimetinib, Encorafenib, Cetuximab regimen has been encouraging. And I think what we've seen, there are patients that can respond, tumors respond, can have improvement in their symptoms. And I think importantly, increased durability of their disease control, more so than we have seen previously. And that certainly provides hope that this is a regimen that can ultimately result in kind of approval and availability for our patients. Obviously, we'll have to wait for the phase 3 study to read out, but we are encouraged that the FDA has recognized this regimen with a breakthrough designation last fall. So they'll be rapidly reviewing the data as that becomes available. So for managing patients with BRAF V600, in particular with the Encorafenib, Binimetinib, Cetuximab regimen, it does require monitoring for eye toxicities. There can be, with the Binimetinib, a kind of transient blurred vision after dosing, but that usually resolves fairly rapidly within an hour or less of the dosing. But working with an ophthalmologist is sometimes needed if those symptoms become more problematic. Overall, the regimen is well tolerated. It is a regimen that really has very limited skin toxicities because of the blunted feedback pathways. So it's the rare scenario where the triplet is less toxic for the skin than individual agents alone. And that, I think, provides benefit for patients.
Issue applied in Ecuador. In the open label phase 3 trial with retrospective phase with BRAF V600E mutated metastatic colorectal cancer. As this disease progress after one or the two previous regimen.
Thank you, Axel. And I appreciate the opportunity, and I apologize that you'll see me up here a few times. but I'll also note that I'm here for the updates, not for the debates, which probably is a testimony to my lack of persuasion, perhaps. But despite that, I'm going to try to persuade you about the relevance here of BRAF V600E mutation. And what I want to do is really convince you of two things. One is that this is a very aggressive subtype of colorectal cancer. And the second is that we actually have therapies that have now moved into clinical practice, and we have opportunities to continue to enroll patients in clinical trials and improve outcomes. So this is the 50,000-foot view, but what I'll be focusing on is really the BRAF mutated subgroup here. So the first point is to reiterate that when we're talking about BRAF, what we're in this context, what we're talking about is the most common mutation, which is the V600E mutation. This is an activating mutation, same one that's in melanoma, some lung cancers, some thyroid cancers. This is a mutation that makes the enzyme constitutively active. Now, as an aside, and I'll touch on this a little later, time pending, that there are other BRAF mutations that are of mixed activity, and some of them are inactivating. And these actually, as Axel has shown, this actually is a group that has better prognosis. So when we talk about BRAF, one of the key things is actually to remember that we're talking about the most common V600E mutation. So,
conclusion: the safety and tolerance and Encorafenib, Binimetinib, and Cetuximab regimen is manageable and accepted for onset, and they establish the regimen as now standard of care for preventive treatment BRAF V600E mutated colorectal cancer.
So the main argument that I would make, and I'll walk you through some key studies, is targeted therapy with just triplet combination should be what should be considered for our patients with metastatic BRAF V600E mutant colorectal cancer, and I'll show you why. So in terms of I just have one slide, and I'll walk you through all key studies. So this is a story of precision medicine, so bear with me. So here I'm showing you data which has led to why FOLFOXIRI with BEV, which Dr. Engel argued in favor of, has been the standard of care for first-line treatment for patients with BRAF V600E mutant cancer. But on the columns on the right, what you're seeing is how precision medicine has truly evolved for this subset of patients with BRAF V600E colorectal cancer. Often, in the world of individualized medicine, the naysayers would say, well, the BRAF is not a real target because the BRAF in melanoma, the same BRAF doesn't behave the same way in colon cancer, and that was truly the case over the last decades. As Dr. Van Kusten this morning pointed out, the studies with BRAF inhibitors alone, the studies with BRAF and MEK in combination, while it almost doubled the responses and survival in patients with melanoma, and even earlier this year, data in cholangiocarcinoma showed the same results. However, for patients with colorectal cancer, it never showed anything. And the reason for that is that on the RAS-RAF pathway, the reason why the RAF inhibition or the MEK inhibition, even a single agent or as together, didn't work is upstream there is upregulation of EGFR, and what happens is the pathway is bypassed through downstream upregulation of CRAF. So what was needed was upstream blockade of EGFR. So you needed to block the pathway at 3 different levels, block the EGFR, block the RAF, block the MEK, and that's what led to the Beacon study with the Binimetinib, Encorafenib, and Cetuximab highlighted at the right end of the slide. What I want you to see is, as you add EGFR alone as opposed to adding EGFR with RAF, which was Dr. Dr. Cope's study, which is also now incorporated into the NCCN guidelines, the SWOG 1406. What that shows is you go from a PFS from like a couple of months to 4 months to 8 months, just the progression-free survival beating the historic overall survival. Same goes with overall survival, a few 5 to 10 months with just chemotherapy. Then you're moving towards 15.3 months, which was the question in one of the previous sessions. Now, if you compare that with FOLFOXIRI with BEV, the initial data from the TRIBE study, the overall survival from that study as well as a non-randomized phase 2, the overall survival coded was in the orders of 19 to 20 months. So granted, that's higher, but remember, that's first-line treatment. And on the right, you're seeing patients who were treated second line and third line. So the fact a second or third line chemo-free combination is achieving an overall survival of 15.3 months, if we extrapolate it to what's going to happen if you bring this up to first line, it will beat chemotherapy, in my opinion. The reason for that is even if you look at the data for patients who had more than 2 lines of chemotherapy or 3 lines of chemotherapy, the survival and the responses were better if you hadn't received more chemo. The other reason why I do think the triplet chemo-free combination will become the standard of care for first line, and I will point out to the discussion that was happening last session, FOLFOXIRI is a triplet chemo in terms of if you look at the median age of these trials. So look at FOLFOXIRI with BEV, the median age was 53 to 67 years of age, as opposed to patients who were getting onto the RAF or EGFR doublet or triplet. Look at the range. There were patients upwards of 80 who the investigators, in their opinion, were comfortable in enrolling them into the Beacon triplet combination. But as opposed to FOLFOXIRI with BEV, as you heard some of our experts even in the last session.
Thank you.